Okay, the first screen is there. Let us go to the first question on the screen. An 11-year-old child drinks. Hello. An 11-year-old child drinks contaminated water and diarrhea sets in. The microscopic examination of stool reveals rotavirus. Plan the child's diet. This is the first question that we have had. So now, firstly, what is the most important indicative point of this diet? If somebody could answer in the comment box, what is the most important indicative? What is the most important indicative point in this diet? No, not bland diet. What is the most important indicative point in this question? The most important indicative point in this question is that the microscopic examination, yes, diarrhea due to rotavirus, absolutely right. So it is the diarrhea due to rotavirus. So now we have to first know about the various complications that rotavirus infection causes for us. Usually we know that rotavirus infection will be affecting the infants or the pediatric age group. It is more prevalent in infants of 2-year-old, 3 years old, 11-year-old. Okay, but it is slowly it starts becoming unlikely after the age of say 14 or 15. At that point of time, if a child is having diarrhea or an adolescent is having diarrhea, we do not initially suspect rotavirus. We rather think about other positive organisms. But here the question is very simple. It has already been mentioned to you that it is rotavirus. Now, basically, what does rotavirus do? Rotavirus is a kind of a virus that eats up or that lives on the lactase enzymes of the brush border of your intestinal villus, and that is what it eats. The lactate enzyme serves as the substrate for rotavirus. So the moment the child gets infected with rotavirus, you can safely assume that the lactase deficiency is going to set in for the child. Now, how does lactase deficiency influence a child's diet? Who can answer? How does lactate deficiency influence a child's diet? If anybody can type in the answer. Is there anybody out here who knows the answer? Please type in the answer. Lactose intolerance. Very good, Ruma. It seems that Ruma is giving all the answers. Other people, please step up. Answer. So lactose intolerance, which means that in this kind of a diarrheal diet, we need to remove all kind of products which contains lactose in it, which means which contains milk in its original form. Now, one must bear in mind that the moment milk gets converted to cottage cheese, chena, curd, the lactose content of milk is considerably lowered or almost zero. That is because the bacteria which are used to convert milk into curd or milk into cottage cheese uses this lactose as their substrate. So they eat up this lactose. So the end product is basically free of lactose. Hence, for this kind of a diarrheal diet, we can safely include milk products which are derived from milk, but we cannot include milk in itself. So this is one of the main reasons of, or the mainstay of the medical nutrition therapy of this particular kind of diet. Since it's a child and milk is an important part of diet for a child, if we are removing lactose from his diet, all kinds of milk products which are made of pure milk are getting removed from his diet. So it poses a kind of a challenge. Though, of course, here he is an 11-year-old child, which means he is not that much dependent on milk for his daily nourishment. But had it been for a younger child, hello? Had it been for a younger child, had it been for a 2-year-old child, then it would have been quite a challenge because the main food items that are a part of the diet. Ankita, I think your mic is resonancing, so maybe you could just mute yourself. So if you can understand that if it's for a 2-year-old child, then it would have posed quite a challenge because a 2-year-old child's the maximum um, foods or the maximum meals that is provided to him are milk dependent, and we have to completely remove milk in its actual form from this particular diet. That is one. Now, when antibiotics will be given for this particular kind of diet, there will also be hampering the other intestinal flora. Okay, so when the other intestinal flora is hampered, that also will aggravate the diarrheal situation. So one of the standard food preparation which is prescribed for these kinds of diarrheal situation is known as the chicken papaya diet. What is a chicken papaya diet? It is a very simple preparation of chicken which has been seasoned with condiments like garlic and ginger, seasoned with other taste enhancing condiments like salt, slight amount of pepper, because pepper is a gastric irritant and we do not wish to give too much of pepper in this meal, and lime maybe to increase the taste. And the speciality of this diet is that the milk, the meat or the chicken rather, is actually boiled with papaya. Why with papaya? Because papaya contains a particular enzyme known as papin. Now, this papin helps to break down the elastin fibers of the meat protein. Then this entire this entire mixture of meat and papaya is pulverized or blenderized, and this broth kind of thing is given to the child at least 2 times, along with other kinds of food which will not have too much of rough fibers or brands in it. Now, why is rough fibers or brands removed from the diet? We all know that rough fibers and brands help in stool formation, but they also are used in situation to cut down satiety. Now, since the transit time of this child has greatly increased, if we give brands, what they will do is they will take in the water that is there in the intestinal lumen, they will blow it up, and there can be additional discomfort for the child. So these kinds of patients, we do not use too much of high fibers or we do not use too much of brands for a limited period of time till the diarrhea is more or less under control. And by control, I mean that the child is not defecating for more than thrice or 4 times in the whole day, and the water content of the diet has of the stool has lowered. Now, so far, is there any questions by anybody about whatever I explained? Please type in your queries. Before I go any further, I would like to clarify any questions that you might have in your mind till this particular. Papin actually will help in breaking down the elastin fibers which are there in the meat protein. So they make it more digestible. What happens is when you are using coarse fibers, like the benefits for the reasons why we did not go into ORS yet. I am not yet even been talking about ORS, so we can take in your suggestions after we finish with the part we are discussing. Fibers, usually when given to a patient, is given with the point that it will give you early satiety. The early satiety part comes because fibers absorb water in your intestine, in your gastric lumen. They bloat up and they give you a feeling of fullness. Now, but for such a patient where the transit time is very fast, we do not want to give coarse brands to these patients, because if we do give coarse brands, they are going to absorb the water, though of course you will say that might decrease the transit time of water, but the thing is the patient is not in a condition to absorb everything correct very quickly at this point of time, since the brush borders have been badly affected, and due to antibiotics the other intestinal flora has been badly affected. So we do not want to give coarse brands or too much of insoluble fibers to this, or not even too much. We do not give insoluble fibers to the patient in a diarrheal situation, be it for rotavirus or any other kind of diarrheal situations. Am I clear to whoever had asked the question? Do you want me to speak in Bengali? Is everybody conversant in English out here?
Ma'am, few of the students are not able to understand Bengali, so it's better if you continue in English.
Okay, fine. So we have completed this much. Now we would be planning, like I said, the chicken papaya diet becomes very important out here, and chicken papaya diet is often used as the main meal during lunch and for dinner. Alongside, what we do is we include milk products which are lactose free to provide additional first class proteins and to provide zinc and calcium to these patients. As somebody already mentioned, ORS is of course provided to any patient who is suspected of having diarrhea or is having dehydration due to diarrhea or due to vomiting. Now, when you are talking about ORS, you must remember that the most recommended ORS is the WHO ORS. I will not be explaining it to you. It is your homework to find out the composition of the latest composition of the WHO ORS, which I will be asking from you in the next class. You will be telling me the answer. Along, if WHO ORS is not available, then sometimes we use substitutes of ORS like homemade ORS. Two, you will be telling me the preparation methods. We use rice water, tea water, dal water, but honestly, since we are talking about a hospital scenario, we are not talking about a rural scenario out here. We are talking about an advanced clinical scenario. Please do not mention things like kanji water, rice water, dal water, and tea water, because those are not actually required as an ORS replacement in an advanced clinical scenario, because here we get the actual ORS which is recommended. And one of the main importance of using the actual ORS is the availability of zinc. Please remember, if it is a rotavirus infection or if it is any other kind of diarrheal disease, the electrolytes which are lost from the body along with sodium and potassium also includes the metal zinc. And please do remember that zinc is a metal, it is not a non-metal. I really find it very, very disheartening when people come up for their internship examination and describe zinc as a non-metal. Zinc is a metal. We've learned about this in our class 5 and 6. So please don't make that mistake. So one of the metals that actually gets depleted from the body is zinc. And in the electrolytes, it's sodium, potassium, and chlorine, which goes out. With zinc, we often see there is a deficiency of magnesium. So basically, we start planning a kind of diet which includes foods along with ORS which are rich in zinc, other electrolytes, magnesium, and protein. Now, why is protein important out here? Because as I've been telling you, there is a cross dystrophy once the lactase is being consummated or the lactase is being used as a substrate by the rotavirus. It does not only eat up the lactase. While in the process of consuming the lactase, it also hampers the structural integrity of the villus. Now, to regain the structural integrity of the villus, we need protein. And you must remember, protein should not be allowed to provide energy. Though protein does provide us with energy, that is not the main function of protein. Protein should always be allowed to repair, to build immunoglobulins, to develop new cells for the various transcription processes that go on. Therefore, we need other nutrients in our diet, which is going to act as protein sparing components. Now, what is the main protein sparing component in our body or in our diet? That is carbohydrate. See, in this particular case, we do not wish to use too much of fat for the simple reason fat has a very different transit time from that of carbohydrate. And here, the patient has an issue with the transit time of nutrient. What is transit time? In case somebody has forgotten, it is a time taken for a nutrient to travel from the stomach or the gastric lumen through your duodenum, jejunum, ileum, finally out of your large intestine. And while it is traveling, it is either getting digested by the various enzymes or it is getting absorbed. The absorption mainly starts from the second half of the duodenum. Till the first half of the duodenum, it is mostly digestion through various enzymes that is taking place, for which we need a particular kind of pH. Sometimes an optimal temperature is required, and of course, we need the required or the particular enzymes for that particular substrate. As we can see here, for the rotavirus case, it has consumed the lactase enzyme, which means lactose will not be digested out here. And what poses a huge problem is lactose is one such substrate which can only be broken by the lactase enzyme. Had it been something like sucrose or maltose, enzymes which can break sucrose are both sucrase and maltase. Enzymes which can break maltose are again sucrase and lactase, but lactose can be broken into galactose only by the lactase enzyme. So the moment lactase enzyme is gone, lactose deficiency is bound to set in. Please remember, this is a very important key point. Lactose can only be broken by lactase enzyme. It do not have any substitute enzyme to break it, which is not the case for many other carbohydrate compounds, for many other disaccharides, because they have lots of disaccharides. Dyes are always the enzymatic forms. Other disaccharides and other polysaccharides are often broken down by multiple disaccharides, but lactase is one such disaccharide which cannot be broken down by any other disaccharides other than lactase. And what does it get broken down to? It gets broken down to glucose and galactose. So I hope you have noted this down. This is the mainstay of the diet. Now, before I proceed any further, let me explain to you how do you go about when you are giving a case presentation. This is something most of you do incorrectly, which results in you getting a lower point in your case presentation. What you people often do is you go into a very generic case presentation. You open the net, you find out lactic acid, lactase deficiency, or you find out rotavirus infection, and then slides after slides after slides, you are just talking about a generic thing about rotavirus infection. For a particular, if you had been asked to give a presentation on rotavirus infection, that is how you could go about. But when you are presenting a case study, for example, this particular case study, then you are not to go into too much of generic details. What you are supposed to present it is basically the initial case parameters. Here, the initial case parameters being an 11-year-old child who drank contaminated water. The symptoms is diarrhea. The microscopical examination has revealed rotavirus. So your differential diagnosis is rotavirus induced diarrhea. Or actually, you don't even need a differential diagnosis out here. You have a confirmed diagnosis that if rotavirus is there in the stool, it's confirmed that it is a rotavirus induced diarrhea. Then maybe on your second slide, because we know that this child has rotavirus infection, you can just give it an overview as to how rotavirus infects the body and what are the complications or what are the consequences that takes place after a rotavirus infection. Don't make it too generic, make it more specific to your case. After stating about the lactase deficiency, don't talk about something which maybe a 44-year-old man with infected with rotavirus can by likely suffer with. Stick to something that an 11-year-old will be suffering with. For example, out here, I can give you the example of like, say for an 11-year-old is, as I mentioned a little earlier, the mainstay of his diet is not milk, which would have been the case had this child been 2 years old. If this had been for a 2-year-old child, then we would have stated that because of the rotavirus infection, the entire dietary regime of the child gets affected. But in this case, it is not so. No 11-year-old is or actually survives only on milk, and we can very easily omit milk in its actual form from the diet for even 15 days, for a fortnight, and there's going to be no difference in the nutrient intake of the child. Along with milk, then you mentioned, which becomes very important for an 11-year-old child, is for an 11-year-old child, he has already been exposed to condiments, which a 2-year-old child maybe hasn't been. By condiments, I mean various kinds of spices. An 11-year-old child basically eats from the family pot. Today's 11-year-old child is been eating pizza, burgers, and all kinds of fast food. That's an 11-year-old child today. So see how your diet planning or how your presentation shifts. What you would be talking about a 2-year-old child will not be similar to that of an 11-year-old child. So when you are presenting this case as a case study, you then talk about the scenario of an 11-year-old, and these are the points that come up. You say that though milk intake will be affected, this will not be very important for an 11-year-old child. We are going to completely omit milk in its actual form from his diet till the microscopical examination of stool reveals there is no longer the presence of rotavirus and diarrhea is also under control. We are going to include some milk products in his diet, which is almost free of lactose, to provide him additional protein, to provide him with calcium, and more so with magnesium. Then we talk about removing foods from diets which are very strong in taste or which can be, as somebody had mentioned, mechanically, thermally, or chemically irritant, which in other words is a bland diet. What is a bland diet? It is a diet which is mechanically, thermally, and chemically irritant to my gastrointestinal tract. Please write this down. A bland diet is something which is mechanically, thermally, and chemically irritant to our gastrointestinal tract. Then, after this, you talk about the generic chicken papaya diet, mentioning that this is a kind of a food which can be included for a rotavirus induced diarrhea for any population group, be it from 2 years to 90 years. Usually, meat or chicken is not given to a child below 10 months of age. So, this is something you can just mention as a pointer. But out here, once again, it is not that relevant because we are talking about an 11-year-old child. So, we can actually use this chicken papaya diet as his main meal during lunch and dinner, and we remove other forms of disaccharides from its diet because we do not wish to burden his intestine or burden his stomach lumen with further digestion. So we remove all kinds of sugar, as in sucrose, from his diet. We try and give him glucose instead, which does not require a further digestion. What do I mean by these? You have to bear in mind, everything has to break down to its monomeric form before the body can absorb it. So sucrose is a disaccharide. It has to be broken down to its monomeric form, which is glucose. It is only then that it can be absorbed. So we remove sucrose from diet, that means we remove sugar from diet, and we include glucose in his diet. We can give him glucose water to increase his calories. Why am I so concerned about calorie increasing? Because we said we are going to give him adequate protein, and we want the protein to help the child's intestinal lumens constituent to get reformed again, which has been affected. Therefore, to allow protein to do its work in repairing the wear and tear, we must give adequate calories, and in this case, the calories has to come from carbohydrate, not from fat. I explained earlier that fat takes a longer time for digestion. It stays in the transit time is very slow. It stays in the stomach, so that just like the brand which I mentioned should be provided during diarrhea, is going to remain. And since there is already a microbial infection, the fat might get decomposed by certain gut unfriendly bacteria which can add on to the problem. So we do not use pastries and creams or too much of fatty foods out here. We always prefer to use butter in such preparations for diarrhea. Why? Because butter does not require, it contains lots of MCT. What is MCT? If somebody could answer. If somebody could type out what is MCT. I'm waiting for somebody to type out what is MCT. None of the students know what is MCT? Very good, medium chain triglycerides. It seems Rumade is the most. Okay, so now a little advanced question. Can you tell me how does MCT gets absorbed? Why is MCT superior over other fats and in the terms of absorption? Have any of you heard about the hepatoportal circulation and the formation of micelle? Okay, it absorbs easily. Why does it absorb easily, Kamran? Okay, this is another answer which is going to be your homework for the next class. I've told you that you have to find out about the ORS. They made easily micelle? No, of course not. Saturation বেশি থাকে না, একদম নয়. Ankita, please don't answer. Hmm. You will be along with, and so I'll quickly recapitulate what are the, it promotes fat oxidation. No, it does not promote, it's nothing to do with oxidation. I'll recapitulate the questions which I've asked you to find out the answer for so far. I've asked you to find out about the WHO ORS composition. I've asked you to find out the substitute ORS composition at home, and this is now your third homework or your third Google homework. You will find out why MCT is preferred over other fats during a diarrheal episode. That is what you're going to Google and find out, or you'll study from your books and find out, and I want the answer from you in the next class, that as to why medium chain triglycerides is preferred over other fats in a diarrheal situation, or in a situation where there are chances of fat malabsorption. Okay, so moving ahead, as we said, we choose butter as the ideal source of fat in such a scenario, and we use minimal amount of butter in these kinds of preparation. So this is the two-third part of the presentation. We end up your presentation usually then go into giving a diet plan for this patient. Usually when you give a diet plan, you can give it in two ways. Either you can give a day plan. If you are giving a day plan, then you mention recipes there. Like for example, I am mentioning for this patient semolina porridge without milk at breakfast. But if I am mentioning specific recipes, it becomes a diet plan for a day. A patient will not be taking semolina porridge or maybe biscuit custard every single day. If you do it in that way, then you have to give at least a 7-day plan. Or what you can do is you can give the food group wise diet plan. For example, you can say cereals without bran or low bran cereals, so much of for breakfast. Before that, what you need to give is the complete list of food groups and amounts, and how you intend to split it into meals. Now, as we all know, as we are continuously saying that for a diarrheal patient, the transit time is increased. Therefore, most of the nutrients are passing through the gastric lumen down the intestinal lumen at a very fast pace, and hence are not getting absorbed. Therefore, what we tend to do is give small meals, so that at least some amount of nutrient gets absorbed. So maybe this particular patient, we are going to plan 6 or even 8 small meals instead of 3 main meals and 2 snacks. So what you do is you give us your food groups, then you give us your amounts, and then you split how much of what food group in grams. Please remember, we no longer use the exchange list. So how much of what food group in grams you plan to give for each of your meal times. And of course, how many meal times you want to break it into is completely empirical. It is your decision. Whatever you do, you will have to justify your diet prescription. If you break it into 6, you will have to justify why you broken it into 6. By justifying, I mean tell us or tell the examiner that why 6, why not 5, why not 8? How are you planning it? If you're making it into 8, if you're making it into 7, if you're making it into 3 would actually be very incorrect for such a scenario. But of course, it's up to you. As I said, diet planning is basically an empirical science. It depends on your particular kind of approach. Okay, so this is the last part of your presentation, where you give us the diet planning, either on a day basis where you include recipes, or you give us the menu planning. The menu planning can be in form of recipes, that's a day menu planning, or you can just give us the food groups, the amount of food groups you wish to include for each of your diet, each of your meals. That becomes a generic planning which can be used by the patients. If you mention after your generic plans that by cereals you mean these obliques, this oblique that, which can be used. Another thing, please pay very careful attention to when you're planning a diet. If you are giving an alternative, the two kinds of things or the three kinds of things you are asking to choose from must be providing similar kind of nutrients. For example, you do not give an alternative between egg white and cucumber. The two of them are completely two different kinds of food. While egg white is a source of albumin protein, cucumber is a source of mainly water, a few nutrients, and some fibers. So they are completely two different kinds of food. A cucumber is ideally not even the alternative to puffed rice or muri. A cucumber can only be, given in alteration of some other kind of similar board vegetables, or maybe watermelon, which is also mostly water, some fiber and electrolytes. You do not give tea oblique egg white. Tea and egg whites are two different genres of food. You do not do that. So this is something you must bear in mind when you are giving food alternatives to the patient. And then finally, you complete your presentation with the chart of foods to be included and foods to be excluded. Please remember, when you are presenting a case, you do not write about those foods which are very, very improbable for your particular case study or your particular case or your specific patient to consume. For example, in this case, it's about an 11-year-old child. So the foods to be excluded should not be including something like tobacco, alcohol. A 11-year-old child is not supposed to be consuming alcohol or not supposed to be smoking. Do not include all that. In the same way, what you can include out here is maybe you don't want this child to have too much of cream cheese pasta. This particular case. Now, had this thing been for a 2-year-old, there you probably wouldn't have written about the cream cheese pasta. So, when you are making your food inclusion and exclusion list, please bear in mind that you are talking about your specific case. You are not talking about a generic inclusion and exclusion list. Had you been doing a presentation only on rotavirus infection, there you might have thought of a generic list. Even then, it is advisable that you make a population-wise categorization of food inclusion and exclusion. What do I mean population-wise? If you open your RDA chart, you will find that nutrient requirement is divided into the various population group for under 2-year-old, from 2-year-old to 6-year-old, from 6-year-old to 12-year-old. These categories are basically known as your population group, which if you have done your community nutrition practical, you are already well aware of. This was just a quick recapitulation of what has already been taught to you by Ankita ma'am, but I hope you can now recall that you've been already told this. So this is more or less how you go about your case study presentation, and I have discussed the case study presentation in relationship to this particular case where an 11-year-old child is having rotavirus infection. Now, before I go into the next question, I will first want all of you to give me a feedback as to whether you have understood everything. If there is anything that you want me to re-explain again, please type it out. I'm waiting. Ankita, are we getting any messages? Has everybody understood?
Not yet, ma'am. Last one was from Kamran.
Okay. So, I will give you another 1 minute to type in your message, or if you want, you can unmute yourself and just ask your question. If anybody is finding typing a large sentence too cumbersome, you can just unmute yourself and you can put up your question or query.
ম্যাম কিউকাম্বারের সময় কি বলছিলি একটু বলবেন?
আমি বলছিলাম যে শশা কি তুমি কখনো ডিমের অল্টারনেটিভ হিসেবে দিতে পারো না, কারণ ডিম ইজ আ অ্যালবিউমিন গিভিং ফুড, তাই তো? এগ হোয়াইট মোস্টলি তোমাকে শুধু কি দেবে? অ্যালবিউমিন মানে প্রোটিন দেবে। আর শশা তোমাকে কি দেবে? শশা তোমাকে জল দেবে, কিছু ইনসলিউবল কার্বোহাইড্রেটস দেবে, কিছু ভাইটামিনস দেবে, আর কিছু ইলেকট্রোলাইটস দেবে। তাই তুমি যদি একটা ডায়েট প্ল্যান করো যেখানে তুমি পেশেন্টকে অপশন দিচ্ছ যে ইদার এগ হোয়াইট অর কিউকাম্বার, দেন দ্যাট ইজ রং। শশার অল্টারনেটিভ হিসেবে আমি তাকে বলতে পারি আপনি তরমুজও খেতে পারেন, শশাও খেতে পারেন। তরমুজ আর শশা উইল মোর অর লেস গিভ মি সিমিলার কাইন্ড অফ নিউট্রিয়েন্টস। যদিও তরমুজ আমাকে অ্যালংসাইড কিছু ভিটামিন এ দেবে in the plant form of vitamin, that vitamin A, that means retinol দেবে না। ও আমাকে কি দিতে পারে? আমাকে খানিকটা জিয়াজান্থিন দিতে পারে, ও আমাকে দিতে পারে খানিকটা কি দিতে পারে রেটিনলের পরিবর্তে? What is the plant form of vitamin A যেটা তোমরা কনভার্সন করো? কমনেস্ট
বিটা ক্যারোটিন।
বিটা ক্যারোটিন, অ্যাবসলিউটলি। সো আমাকে খানিকটা জিয়াজান্থিন দেবে, আমাকে বিটা ক্যারোটিন দেবে, যেটা শশা আমাকে দেবে না। বাট মোর অর লেস ইট ইজ সিমিলার। বাট আমাকে শশা যেমন অনেকটা মাত্রায় ম্যাগনেসিয়াম আর জিঙ্ক দেবে, সেটা আবার আমাকে ওয়াটারমেলন দেবে না, বাট দোজ আর স্টিল অ্যাকসেপ্টেবল। বাট এগ হোয়াইট এন্ড কিউকাম্বার ইজ নট অ্যান অল্টারনেটিভ, ঠিক আছে? আর কারো কোনো প্রশ্ন আছে?
Had it been
Ma'am, it has been what? I could not read. Ankita, what was this thing?
ma'am, had it been a 2-year-old child, then what will the food given for lunch and dinner? Because for 11 years old, the child has choices, whereas for a baby, there's not much of a choice.
Yes, had it been for a 2-year-old, then it would have been much more a challenge for us. As I said, chicken and papaya diet is going to be the mainstay for both the 2-year-old child and the 11-year-old child. For the 2-year-old child, since the rest of his diet is mostly mashed food, here we will think about inclusion of a mashed banana. We can think about inclusion of stewed apples. We can think of inclusion of small portions of chena. We can think of including, if the child is tolerant to curd, maybe a little bit of curd or maybe a little bit of biscuit custard to provide that extra carbohydrate to his diet. We can think of including small amounts of egg white, preferably soft-boiled egg whites. Too hard-boiled eggs makes the egg white into a very complicated, complex protein which becomes very hard to digest, especially when you are having indigestion or when your digestive system has been grossly affected. It is basically the soft-boiled egg. The protein coagulation is still not that extreme to form an extremely complex protein. So soft-boiled egg whites can be given, or maybe a little portion of the egg yolk also from a soft-boiled egg can be included for a 2-year-old child. And definitely for a 2-year-old child, the meal pattern needs to be broken up into 7 or 8 small meals throughout the day. And complete exclusion of milk in its actual form. I hope that answered your questions. Is there any other questions regarding this, Ankita? Is Sweta still with us? Is
No,
Sweta
ma'am, I don't think so. She is online. One more
soya
question.
milk yes দেওয়া যেতে পারে, but soya milk should not be used for a 2-year-old child. 11-year-old কে আমি একদম দিতে পারি। Sucrose should not be given. এতক্ষণ ধরে বোঝালাম সুপ্রিয়, where were you? No, I want to avoid other disaccharides because once a particular disaccharide dies, is affected, there are chances of other disaccharides also to be affected. So আমি যতটা সম্ভব disaccharides remove করব from diets and monomeric formulas দেব, যে কারণে বললাম সুক্রোজ দেব না, গ্লুকোজ ইউজ করার চেষ্টা করব। Shweta has left. Ankita, is Shweta here?
No, Shweta was not online.
Yeah, I saw Shweta's signing in actually. Okay, Shukri, good that you've understood. No, I just wanted to know if Shweta has already. Is breast milk?
Yes, Shweta is
Please
there.
remember, if the child is less than 2 years old or up to 2 years old, there will be continuation of breast milk feeding as usual, because the immunoglobulins that are there in the breast milk will always help the child to recuperate faster. So there will be no stoppage of breast milk under any situations. There are only very few conditions when breast milk is asked to be stopped. Rotavirus infection is not one such.
Shweta is online.
Okay, Sweta, have you already discussed any further points regarding rotavirus to them, or is there anything else that you would like to add to this, or then we can move ahead with the next question? Sweta, are you online?
हाँ मैम ना मैम आपने तो जेटू को आपने
You need to speak in English because half of the people out here don't understand Bengali.
I think what you have explained is clear enough for them. I do not have to add anything else. Diet and all, everything is clear, ma'am.
So this is that is okay, and then moving ahead to the next question, Sweta.
Yes, ma'am. Yes, ma'am.
Okay, and if you have any further questions, Sweta ma'am is always there to explain anything you have not yet understood. You can ask her later on in your groups. Is that okay with you also, Sweta?
Yes, ma'am. Yes, ma'am. Always okay.
Okay, now one thing that all of you will have to do, Sweta, please take note. You will be planning out the diet plan for this 11-year-old, and you would be sending them to Sweta ma'am. You can write it down on pieces of paper and take screenshots and send it, or you can mail it to Sweta ma'am. I'm sure you have a particular mail ID which is created for your internship. If you haven't, Sweta, please create a mail ID for these people so that there they can give you answers to the questions that are being posed to them.
I have the mail ID. I will share with them later on.
Okay, so ma'am is going to share it. Will share her mail ID with you, and you will be planning giving the diet plan for this particular case, and you will be giving her the answers. She will be checking it, and you have whatever is being taught. You will be having just 1 week to give an answer, because next week the next class, before the next class, whatever questions are being discussed today has to be completed. We'll try and complete 12. I don't think at the pace we are going, we'll be able to complete 12 questions. At least we'll try and complete 10 questions today.
Okay.
Okay, so we are proceeding to the next question. Is that okay with everybody? And nobody has any further questions regarding this first question. So if it's permitted by everybody, I will proceed to the second question. Ankita, if you could kindly share your screen again so that the second question could appear on the screen.
Ma'am,
Asmita, you can mute yourself otherwise.
Ma'am, it's already done. I guess there is some network issue in your end, so you are not able to see.
Okay, then I'll just read it out. The second question, I hope everybody is being able to see it on their screen. In case you can't, I'm reading it out to you and you can write it down. A 50-year-old obese chronic alcoholic male patient with hypertension, and the values are given. It is 190 systolic with 110 diastolic mm of mercury, was admitted 1 week back with the weakness of the right side of the body. I'll repeat the question. A 50-year-old obese chronic alcoholic male patient with hypertension, whose values are, the pressure values are 190 systolic with 110 millimeter of mercury diastolic, was admitted 1 week back with a weakness of the right side of the body. Enumerate the dietary principles of the patient. We also have certain other. Okay, it's already been typed in by Ankita ma'am. The lipid profile is LDL is 300 mg per dl, HDL is 25, TG is 315 mg per dl. So, What were the point of concerns in this questions? What are the questions? What is there? The keywords that we need to look for in the questions. Who can tell me the first three keywords that is important in this question? HTN, okay. Dyslipidemia, okay. HTN, yes. And you're missing out the first two keywords. Obese, okay. Obese, alcoholic, okay. Can somebody relate alcoholic, why alcoholic became so important out here? Okay, hyperlipidemia, dyslipidemia, very good. So why is alcoholic very important out here? Not only liver damage, we do not have a liver profile out here. Alcohol not only will harm the liver, the patient is there is no history of liver cirrhosis out here. Please read the question. There is no history of fatty liver. There is no USG report out here. There is no mention of palpable liver. That is not mentioned in the question. So don't draw in stuffs which is not given to you. Don't unnecessarily complicate. Yes, somebody is meant. Okay, obesity, it increases the, no, what is the main importance is alcohol is empty calories and alcohol will grossly lower BMR. No, the BMR of this patient has not been mentioned anywhere. Alcohol does not lower or increase your BMR per se. It is obesity which can might affect your BMR. But then it is you become obese because of a low BMR and not the other way around. No, necrosis, you're taking it too far. We are saying we are not thinking about NASH out here. Nothing in this question is yet indicative of NASH. So please do not bring in NASH when it is not described in the question. Make it very simple. What is there? Alcohol will affect the dyslipidemic condition of the body. Yes, somebody has come up with it. There is a weakness of the right side of the body. Alcoholic, dyslipidemic patient have chances of forming of thrombus or plaques in these. This can actually lead to paraplegia or hemiplegia. This patient is already complaining of weakness in the right side of the body, which means the patient might be showing signs of hemiplegia. There might be a CVA for this patient. There might be a thrombus formation due to the high lipid profile, the high LDL level and the high TG level of the patient. Alongside, you will also note that the patient has a pretty low HDL level. Now, as we all know, from a very layman's term, LDL is your bad cholesterol, while HDL is your good cholesterol. Why is HDL your good cholesterol? Because it is your scavenger cholesterol. What does HDL do? It usually removes the plaques which are getting formed in your arterial, which is sticking to your arterial wall. Now, can anybody tell me what is the composition of the plaques which slowly starts getting formed around your arterial wall, and in which part of the arterial wall, which section of the arterial wall does the plaque usually affect? What are the three sections of the artery? What are the three histological sections of the artery? If you go from inside to outside, what will be the three sections of the artery? Tunica intima. What are the other two? Okay, write down. This is once again another homework. This is basic physiology which you should have known. You will find out what are the three sections of the tunica media. Yes, the last one. Okay, so some of you seem to be knowing the answers. The rest of you, if you've noted out, Very good. Tunica means, okay. So now where does the plaque usually form? Does it form in the tunica intima? Does it form in the tunica adventitia? Does it form in the tunica media? Plaque is formed in the tunica media. Very good. Now, what is the composition of a plaque? Kamran, can you give it another try? Because you've been giving correct answers so far. What is the composition of the plaque? Does anybody know what a plaque normally formed of? Hydrogen peroxide? Hydrogen peroxide? Reliever, it's a bleaching agent. You're going to die if hydrogen peroxide is cholesterol. It's not just plain cholesterol. It is something with cholesterol. The abnormal components of a plaque. It is somebody's already given partial answer, cholesterol, and what else? I'll just give you a hint. It is basically you have to think about the various elements of the activity series. Calcium, yes, Priyanka, you're absolutely correct. It's calcium, it is cholesterol, a combination of calcium and cholesterol actually forms the plaque. Now, why is the plaque formation even more plausible in this particular case? What particular parameter of this patient tells us that he is more prone to plaque formation? Please read the question. 50-year-old obese, chronic alcoholic. So basically, it's alcohol which is increasing his dyslipidemia. No, the alcohol is increasing his dyslipidemia. So that is increasing his lipids. So then that he has more lipids. One part of the story. Another parameter is mentioned out here, which is going to accentuate his plaque formation. What is that? It's read the first line of the question very carefully. A 50-year-old obese chronic alcoholic male with hypertension. Does that? Yes, very good, Roma. Hypertension. So when a patient is hypertensive, what happens to the arterial walls? They basically lose their contraction, their vascularity, isn't it? When a patient is hypertensive, the arterial walls, they lose their vascularity, and when the walls loses their contractibility, they are not able to, pump the same way. And if you could pump with adequate pressure, then the chances of the plaque staying in a particular place reduces. But with hypertension, the arteries do not pump, or the flow in the arteries are not as smooth as for a non-hypertensive patient. And in that case, the plaques settle more easily. There are more chances of thrombus formation. Absolutely correct. So this is basically the mainstay of this particular case. So from a dietary point of view, we need to address the dyslipidemia condition. We need to address the hypertensive condition, and we need to address the obesity condition. Now, somebody had mentioned BMR, but in a very wrong context. Out here, you have to assume that the BMR of the patient is basically very low. That is one of the reasons why a patient gets obese. When our total energy expenditure, or the resting energy expenditure, or the energy expenditure that we calculate through a Harris-Benedict equation is very low for a particular patient, then their metabolism slows down. The moment your metabolism slows down, you will be developing obesity. So here we would try to increase the BMR of the patient. How do we go about doing that? We need to get the patient to eat in such a way so that slowly the BMI comes up. That is giving food in small intervals and alongside asking him to become more physically active. More or less, we would see if we take a diet history of this patient or if we take a lifestyle history of this patient, we find that the highest possibility is that this patient is 50-year-old, he's probably a corporate worker, he's a sedentary worker. So to increase the BMI, we must get him to increase his activity level. His total PAL value needs to go up. That is one thing aside from the diet that we need to advise. And from the dietary point of view, he needs a low fat, low sodium. Please remember, it is not a low salt diet or it's not salt restricted. It is a low sodium diet because you must remember that sodium is not only available in diet as NaCl or common table salt. There are so many foods that we consume on a daily basis which contains high level of sodium. Those being the various preservatives this is added to food, those being masked as baking powders. So foods which use baking powders like the bakery products, your regular bread, your cakes, your biscuits, anything that requires baking powder, which is sodium bicarbonate, comes again, increases your sodium load. Preservatives, sodium benzoates, they increase your sodium loads. Pickles, etc., have salt. We do not bear it in mind because we are not actually seeing the salt in pickles. We do not, what escapes our attention is that we forget to remember that salts are also there in pickles. So, another very important long term habit that this patient needs to develop, or for that matter, any patient who is hypertensive and dyslipidemic has to develop is a habit of label reading. Whenever he is buying packaged food, he has to learn or has to develop the habit of label reading. See, when you are presenting this particular case, once again, as I said, you will never present a generic case study. It has to be specific for this patient. 50-year-old alcoholic, I am assuming he is an educated person, and I'm also assuming that he resides in a city, which means he is exposed to tin foods or packaged foods. Therefore, your dietotherapy regime would also include educating the patient about label reading and what are the points that he should know when he is reading the label. Whether the food he is buying has high amount of preservatives, what kind of are the sodium containing preservatives, do they have more than 10% of fat in them? Do they fall under the junk food category? What falls under the junk food category? Anything where energy is coming from more than 20% of simple carbohydrates will be junk food. Any food where the energy source is from more than 20% of simple carbohydrates or carbohydrates is considered as a junk food. So he'll have to note while he's reading his labels whether they fall into the junk food category or how much of carbohydrates are there which are giving energy. He has to note whether there is any hydrogenated fat in the kind of food or the packaged food that he is buying. And he has to know if there is any other nutrient which might be interfering with his condition. So you must educate the patient about label reading in such a scenario. Any questions so far about this particular question? Any questions that any part that you haven't yet understood what I have been discussing? Ankita, is there any হেমিপ্লেজিয়ার জায়গাটা আরেকবার বলবো। ইয়েস, নিশ্চয়ই বলবো। হেমিপ্লেজিয়া মানে কি? প্যারালাইসিস, সিভিএ এর পরে হচ্ছে সেরিব্রোভাস্কুলার অ্যাক্সিডেন্টের পরে যদি কোনো কারণে তোমার প্লাক গুলো ফর্ম করে দিয়ে যদি কোনো সেখানে তোমার রক্ত চলাচল আটকে যায়, যদি তোমার ব্রেনের কোনো একটা জায়গায় গিয়ে একটা প্লাক ফর্ম করে যায়, যেটা এই ক্ষেত্রে ভীষণভাবে সম্ভব, কারণ এর অ্যাজ ইট ইজ ডিসলিপিডেমিয়া আছে এবং এর হাইপারটেনশন আছে, তখন এর প্যারালাইসিস হতে পারে। মেডিকেলি ইট ইজ হেমিপ্লেজিয়া অর প্যারাপ্লেজিয়া। হেমিপ্লেজিয়া মানে একদিক পড়ে যাওয়া, এর শুধু রাইট সাইডে উইকনেস বলছে, সো দ্যাট ইজ ইন্ডিকেটিভ অফ রাইট সাইড হেমিপ্লেজিয়া। মানে এর হয়তো অ্যান ইনসিডেন্ট অফ স্ট্রোক, মানে সিভিএ। স্ট্রোক মানে কিন্তু হার্ট অ্যাটাক নয়, হার্ট অ্যাটাক হচ্ছে মায়োকার্ডিয়াল ইনফাকশন। মায়োকার্ডিয়াল ইনফাকশন ইজ ইয়োর এমআই। আর সিভিএ মানে হচ্ছে সেরিব্রোভাস্কুলার অ্যাক্সিডেন্ট, which কমন টার্মে আমরা বলি স্ট্রোক হয়েছে। স্ট্রোক হওয়া মানে কিন্তু হার্ট অ্যাটাক হওয়া নয়, হার্ট অ্যাটাক ইজ মায়োকার্ডিয়াল ইনফাকশন। আথেরোস্ক্লেরোসিস থেকে যেটা হয়, আর আথেরোস্ক্লেরোসিস যদি ব্রেনে হয় সেখান থেকে আমার সিভিএ হতে পারে, which is stroke or cerebrovascular accident. Cardiovascular accident কি বলে বলতে কোনো টার্ম ক্লিনিক্যালি ইউজড হয় না। ইটস cerebrovascular accident which is indicative of stroke. মাথার কোনো একটা আর্টারি বা ভেনের মধ্যে তোমার প্লাক ফর্মেশন হয়েছে, which leads to paraplegia or hemiplegia. এই কেসে রাইট সাইড উইকনেস বলছে, মানে ইটস রাইট সাইড প্যারাপ্লেজিয়া। আর কোনো প্রশ্ন এখন অবধি?
ম্যাম একটা কোশ্চেন এসেছে, দ্য ডায়েট প্ল্যানটা কি এইচটিএন? এইচটিএন আর হেমিপ্লেজিয়া কি করে সিমিলার হতে পারে বাবু? কে বলছি? সায়ন?
বাবু, HTN এর জন্য, HTN is one of your predisposing factors which progresses towards hemiplegia. মানে hemiplegia হতে পারে because তার hypertensive and LDL. HTN is hypertension and hemiplegia হচ্ছে paralysis, দুটো এক জিনিস নয়, কিন্তু হাইপারটেনশন থাকলে পেশেন্টের প্যারালাইসিস হওয়ার সম্ভাবনা বেড়ে যায়। ঠিক আছে? First is to prevent HTN. Note এখানে first বা second নেই, এটা both তিনটে সাইড বাই সাইড যাবে। পেশেন্টকে ডিসলিপিডেমিয়ার জন্য ম্যানেজ করতে হবে, পেশেন্টকে হাইপারটেনশনের জন্য ম্যানেজ করতে হবে, পেশেন্টকে ওবেসিটি রিডাকশনের জন্য ম্যানেজ করতে হবে। এবার দেখো, এই মুহূর্তে পেশেন্টটাকে যেহেতু অ্যাডমিট করা হয়েছে, আমি তো তার ফিজিক্যাল অ্যাক্টিভিটি বা তার প্যাল ভ্যালু বাড়ানোর সাজেশন দিতে পারবো না। তাই এই ক্ষেত্রে দ্য আইডিয়াল ওয়ে অফ প্রেজেন্টিং দ্য কেস would be first providing with the hospital plans, which would be basically a low sodium, low fat diet plan. What you can give is a 3-day plan. In this case, in a hospital plan, I would basically be giving 3 moderate meals, none of them too heavy, and 2 small snacks to the patient. Because you have to see that the patient is admitted, the patient is already having weakness on the right side, so he might not be able to masticate his food very well. So in that case, the patient would probably be requiring a soft diet. Okay? See, a bland diet is not required in this case. But as you know, a standard therapeutic diet in the hospital is always on the fringes of being bland. We do not prepare food with a huge amount of spices and condiments in the hospital. No hospital therapeutic diet is prepared with a huge amount of condiments. So basically, we do not require a overt bland diet for this patient, a standard therapeutic non-vegetarian diet which is low fat is suggested to this patient alongside the diet patient also needs to get a low sodium diet. For that, first thing is of course salt reduction. So what you know as while you're doing your internship, you know you have the low salt diet, and the way a therapeutic diet is planned, it is usually low sodium. Unless and until we specifically include certain foods, we do not provide high sodium to a patient through diet. If a patient is having hyponatremia, which means low sodium, or a patient is having hypokalemia, which means low potassium, which can so happen in the case of the previous question that we discussed, in cases of diarrhea or vomiting, where we often encounter low electrolytes, then sodium and potassium is often provided to the patient separately through dab water, through tomato juice, through sometimes extra salt, through ORS, but a standard therapeutic diet which is planned for the patient, which is simply coded as INV or INV by D, or INV, IVP. INV by D would of course be diabetic. Now here, a point of note is from the practical point of view, a low fat diet would be very similar to a diabetic diet, though this particular case out here has no mention of hyperglycemia, or there is no mentions of glycated hemoglobin levels being elevated. Probably, in all possibility, this patient will show a hyperglycemic tendency if tested. So, if we do include our diabetic for safety's sake, we also include the diabetic precautions for this particular patient, we would not be entirely wrong. Now, as I was saying, in this particular case, there needs to be a two-stay kind of diet presentation. Because he is admitted, a 3-day hospital plan, and then there is going to be a discharge plan for this patient. During discharge plan, we take into consideration of making it low calorie because we need to increase the obesity. But for low calorie, what we need to do is we need to find out what is the activity level of the patient, and from the activity level we need to either actually calculate the PAL values, which will tell us the physical activity. PAL is, what does PAL stand for? I have been continuously using this term PAL value. Does anybody know what? Ankita, somebody just type something about glycated hemoglobin. What was that? I missed it.
HbA1c may be advised that you have already said. That's what.
HbA1c lab. A test for HbA1c maybe should be advised. Probably will be advised by the consultant physician. If not, the consultant dietitian can also advise for it. And if it should definitely be advised upon discharge. You should definitely, if the patient is under your care post discharge, you will ask the patient to come back to you after the 1 month review with a report for preferably HbA1c rather than fasting glucose, because that is going to be indicative as to whether he is developing diabetic tendencies. A better prognostic tool to predict diabetes or upcoming diabetes than fasting or PP sugar. While on this matter, let me just quickly remind you that a patient is not declared to be diabetic unless and until there are 3 consecutive fasting PP reports which are showing hyperglycemia. With one report, a patient cannot be declared as diabetic. Please bear this in mind. Okay, so we would proceed to what I was. Does anybody know what is the PAL value? What's the full form of PAL? Physical activity level. Very good, Meghna. So then through your recall, the last day recall, you would be able to understand what is the PAL value of the patient. Based on the PAL value, you can know the activity factor. Through that, you calculate the required basal energy for this patient, or the TEE, total energy expenditure for this patient, and you will be knowing the basal energy expenditure for this patient. You would be able to figure out the BMR of this patient. To increase the BMR, what you do is you ask to increase the activity factor to maybe a step 1, like +1, and you start reducing 300 to 500 depending on how much you feel the patient will be able to reduce at one go from his daily intake, whatever is this intake of food right now, which you can find out through a diet recall pre-admission. Whatever he's eaten in the hospital should not be taken as a dietary recall, because that has been something which has been sent under the monitoring of the dietetics department. So that is not the diet recall results that you need to plan his discharge diet. The diet recall that you need to plan his discharge diet is his pre-admission diet, or maybe his pre-illness, pre-symptomatic diet, which was his normal diet before he had this particular symptom of, feel a weakness of the right side, or maybe an episode of unconsciousness, which might have happened in this case. So from that particular diet recall, you reduce 300 to 500 kilocalories depending on the PAL value of your patient, and that will help you to increase the BMR of the patient. Once the patient's BMR starts going up, once the metabolic rate of the BMR of the patient starts going up, he will automatically start losing weight. The obesity problem will be addressed. And if you are giving him a low fat diet, ensure you're also giving him a low carbohydrate diet, in the sense you are giving him low simple carbohydrate diets. Please remember, carbohydrates do not come only from your disaccharides, your fibers, your vegetables, your fruits. Everything is giving you carbohydrates. So when in real life you encounter some clinician telling you to give a no carbohydrate diet, please turn around and say that a no carbohydrate diet means I'll have to feed water only to the patient. Because even when you're practicing in your clinic, you will find some patients coming to you and telling you that, I'm on a no carbohydrate diet. Nobody is on a no carbohydrate diet. Basically, most of the people are under this notion that carbohydrate means cereal products only. No, that's incorrect. As you all, as students of dietetics, know that carbohydrate comes from fruits, vegetables, even from various kinds of meat products, fish products, except for egg, which basically has almost zero carbohydrate. Even meats and fish has some amount of carbohydrates in them. Vegetables and fruits are basically all only carbohydrates. They have maximum of carbohydrates, some soluble, some insoluble, water, vitamins and minerals. That is basically the compositions of fruits and vegetables. They do not contain much of fat, or they do not contain much of protein. But also, once again, remember, which also does not mean that fruits and vegetables are devoured of fats and proteins. If you open your Gopalans, you will see, if you open the proximate principle table, you will see that all fruits and vegetables also contain trace amounts of proteins and fats. Like in the same way, you will see your meats also contain trace amounts of carbohydrates, and fruits and vegetables should always be there in a diet. Nobody can survive on a no carbohydrate diet, and especially all these keto diets that are coming up, which is protein only diets, are grossly defective, grossly like incorrect diets. They are going to grossly affect the body's normal metabolism. They are going to increase the urea creatinine ratio of the body. They are going to disrupt the blood urea nitrogen, which is going to badly damage the kidneys, the nephrons, and the liver. The last thing we want this patient to suffer from, as he's already alcoholic, is additional liver and kidney renal problems. So for a discharge diet, you decide on a low fat diet, but remember, while you are giving a low fat diet, try and increase the HDL level of the patient. How do you do that? There is certain fatty foods or fat containing foods which are very good sources of HDL, those being walnuts, pecan nuts. Now, pecan nuts is not something once again which is very easily available in at least Kolkata. They are now available in some of these Spencer's Hyper. If you are including pecan nuts, mention that this can only be available in high end grocery stores. Walnuts, roasted walnuts deskinned. Acha, please remember, almonds, walnuts, pecan nuts, all kinds of nuts are to be consumed deskinned because the skins of these nuts contain the component HCN, hydrogen cyanides, which is a precursor of KCN, potassium cyanide, which you know is a gross respiratory toxicant. So we must remove the skins. We must tell the patients to have either roasted almonds, which upon roasting the HCN gets destroyed, or de-skinned almonds and walnuts. In fact, walnuts are a bigger source of HCN than almonds, but these actually give you good cholesterol, or these actually give you HDL, which you need to increase in the diet. The HDL level of this patient should go up to around 50 to 55 mg per DL, while his LDL and TG should come down. And please remember, TG usually increases more from simple carbohydrates rather than from fat intake. So, the simple carbohydrate intake of this patient needs to grossly come down. That was the reason why I was suggesting that if his diet plan is similar to that of a diabetic patient, you will not be grossly diverting from your path of treatment. Because since his triglyceride is high, we have to remove simple carbohydrates from his diet, because simple carbohydrates gets metabolized into triglycerides in the body, which later on enters the beta oxidation. It does not enter the beta oxidation, I'm sorry, it enters into the cholesterol formation pathway. Am I clear so far? Anybody has any question? Okay, so I will then quickly once again recapitulate what I said about the mainstay. The patient will have a low fat, low calorie diet, low sodium diet. You have to educate him about food label reading. These are on his discharge diet notes. Foods to be included and excluded should be done bearing in mind he's a 50-year-old. Here we mention do not consume alcohol because it is mentioned in your question that this patient is a chronic alcoholic, which means he might be consuming tobacco as well. So here you can mention all that. Maybe this patient also might be eating too much of red meat, so that can be included into the diet. That do not have too much of red meat. Stick to white flesh, which means chicken and fish. You should mention about not consuming fish heads of any form, because all kinds of fish heads contains cholesterol. You should mention about not having the shells of the crustaceans because they consist of cholesterol and a good source of calcium. Both we don't want, because this patient has a chance of plaque formation. And pre discharge diet is something which you also need to show for this particular case study, since the patient is admitted in the hospital. That would be a 3-day hospital diet. Now, when you're putting up a 3-day hospital diet, there you can actually mention your menus, because in the hospital there would be a specific menu which you will select for the patient. There you do not give options to the patient. It has already been, you would be visiting the patient in the morning, During your rounds, you would be discussing the options available with him, and then there would be one specific food that is being sent to the patient. In a hospital diet, we do not send, say things like the patient might have liquor tea slash normal tea slash something, because I know I'm going to be sending the patient only one kind of tea. When you see the hospital menus, there you will see options. Now, those options are given for the dietitian to know that what are the things that she or he can offer to the patient. But when you are ultimately writing down the diet prescription of the patient, their options no longer exist, because you have already decided on what you're going to give to your patient, and therefore there you write the specific menu that is being sent. You do not write gold vegetables oblique mixed vegetable oblique something like that. Find out what is that specific vegetable that you want to give. You want to give the soft vegetable with contains gold vegetable, or you maybe want to give pumpkin to that patient. So mention just that. So that will be 3-day hospital menu. And then a discharge menu. On a discharge menu, I would always recommend that you present your foods in the food group format rather than in a menu format, because if you're giving a menu format, the patient will not be following one particular menu for the rest of his 1 month till he comes back to you for his review. Is best to give him the food groups and the amount of that particular food group which is allowed at that particular week time, and to mention the various options that he can get in those various food groups alongside as a footnote. Am I clear so far? So this is the second diet chart that you would be sending to Sweta ma'am. Now let me come. I don't think we'll be able to even finish 10 questions. Let me come to the third question. I think I'll explain the third question and call it quits for today, because we are going at a very slow rate as I can see. But I want you to be completely thorough with what we are saying. So these sessions are going to be longer than I expected. This is going to be more than 7 classes, but I want you to be completely thorough with what I am explaining to you, and so that your knowledge is completely, you do not have any lacuna in it. Yeah, Ankita, could you just share that message that you just wrote? A 60-year-old man who is edentulous has developed squamous cell carcinoma in the cheek. In the cheek portion is not mentioned in the question. You please add it down to your question. A 80-year-old man who is edentulous has developed squamous cell carcinoma in the cheek. He is also suffering from celiac disease. So what are the points what are the key points of his disease, of this case? Who will tell us the key points that will dictate his medical nutrition therapy? There are 3: celiac disease, okay. Other 2, squamous cell carcinoma in the cheek, very important. More than cancer, it is the site where the malignancy has occurred. Squamous cell carcinoma in the cheek would be indicative that the patient had lots of oral ulcers or aphthous ulcers in his mouth, which means he will not be able to consume food other than something which is very bland. And there is another thing which is staring at us. He is without teeth. Which word means without teeth? Edentulous. Edentulous. The spelling is incorrect out here. It's edentulous. So that means he's without teeth. He's 80-year-old, he's without teeth. He has squamous cell carcinomas in the cheek, which means he has aphthous ulcers, and he has celiac disease. So the moment celiac disease comes to our mind, we think about gluten enteropathy, which means all kinds of gluten or wheat products, gliadins, needs to be completely removed from diet, which means we cannot use maida, any kind of maida products like bread, cakes, biscuits, etc. in his diet. There are also chances of foods like custard powder, which comes with a mixture of corn powder mixed with maida. So it's best to stay away from any such powders which are used for premixes. Your soup thickeners, they also sometimes come with flour and maida. Commercial powdered soups, noodle soups, and things like that comes with additional gluten. So you must here. There's no point in educating this gentleman in label reading because he's 80-year-old. He probably doesn't do his own shopping, so his family members must be told about gliadin, must be explained about gluten and to avoid the products which contains gluten. And secondly, this patient needs to have more or less a semi-solid diet or a full fluid diet which is without any strong tastes, which is bland because he has squamous cell carcinoma in the cheek, which means, I'm repeating myself, he will be having aphthous ulcers all over his cheeks. So he would be needing food in basically a semi-solid form or probably as a full fluid diet. A full fluid diet is something which can be completely balanced. It is not as inadequate as a clear liquid diet. It can be a completely balanced diet only which has been pulverized. If the patient can afford, you can add on some commercial formulas to his diet plans because sometimes it becomes very difficult to plan out kitchen feeds in a full fluid diet and meet all needs. Especially since this patient has carcinomas, he might be needing additional supplementation of glutamine, he might be needing additional supplementation of ornithine. These are very difficult to be included in diet through normal kitchen feeds. So what we often do is we add on some commercial nutrient, which is some commercial formulas. Like for example, maybe for this patient, I might include ProSure, I might include metaglutazedis, I might include immunoglobulins in forms of Immunomax. These are various kinds of commercial formulas that are required for the patient. So, Sweta, you're there. If you could kindly, if the patient.
The class is due.
That class is due. So you can just quickly just note down the names that I'm telling you. Sweta ma'am will be taking a class on you where she will be giving you the available commercial formulas in at least the Calcutta market right now and which is used in what kind of scenario. So that will be a separate class where your therapeutic commercial formulas, the MNTs will be discussed with you. But right now, you can just write down the names. Keep a pointer so that you can ask Sweta ma'am once she is taking your class. So this is what we need to do for this patient. And once again, for this patient, will not be able to consume large meals. Preferably an elderly gentleman. But remember, he's an elderly gentleman and there are chances of him falling drowsy. And if he's having carcinoma, that means he has, if it is in a malignant state, if there has been metastasis, he is in pain. So often, more than often, if not less, he would be on some kind of pain management drugs. Most of the pain management drugs usually induces drowsiness in the patient. So if you are feeding him a liquid kind of a semi-solid kind of food, there are chances of aspiration. And the last thing we want for this patient is aspirational pneumonia to set in. So the patient must always be fed at a propped up state. That means when he is sitting at an elevated angle of more than 45 degrees, should not be allowed to be put in a supine position or in a flat sleeping position. At least till 45 minutes of the meal, and remember not to feed the patient too late into the night or towards the later half of the night. His last meal should preferably be around 8 o'clock. Try to see that your meals are taken before his pain medications, which might induce drowsiness. So, find out his medical prescription, find out if he is on any opioid derivatives, any morphine derivatives have been given to him. Secondly, if the patient is receiving any kind of chemotherapy, the patient will have gross nausea. In that case, you what holds very good, what gives a wonderful sustainment during nausea is if you can give some kind of cold foods to the patient, not freezing cold, a little amount of cold fizzy drink, something like Sprite, often relieves the vomiting tendencies to the patient. Dry crackers can be given, but in this case, I don't think the patient will be able to handle dry crackers because he has squamous cell carcinoma in the cheek, which can lead to aphthous ulcers. So maybe if he is on chemotherapy, you can add some fizzy aerated drink which contains less amount of phosphoric acid. So the few names that comes to my mind are 7 Up and Sprite. I would not want to give Limca because Limca is sour in taste, and maybe the sour taste will not be tolerated well by the patient because it might give a burning sensation if he has aphthous ulcers. If there is no problem of aphthous ulcers, you can even think about including Limca or something like that, aerated drink to his diet. Please don't include any cola drinks. That is going to help him with his nausea tendencies. Even cold iced teas, lime julep kinds of things can help in these kinds of patient. Cold apple, fizzy apple drink like Appy Fizz and things like that, if it is not too sour, can be given to the grape. One is actually very less sour, more sweet. The fizzy grape drink that Apple Fizz company has taken out. Such kind of things can be given to the patient if he has nauseatic tendencies. Because remember, not only does chemotherapy drugs, even opioid drugs, which will be probably be given to this patient,
And the food is the thing that I've been saying last week, and I don't think, Ankita, should we go ahead with more questions? I believe we've already been discussing over 2 hours, and I think the students should be time to assimilate the information.
Yes, ma'am. I think today we should end the session with these three questions only.
yeah, so I can understand, I guess we can all understand that these are going to be a little long sessions. I intended to finish 12, but it's not possible to finish 12 questions. So we'll have the next session, I don't know, preferably on coming Saturday maybe or Sunday. You will be included.
Ma'am will inform them.
Yeah, we'll inform you all. And if you have any questions regarding the third scenario that we discussed, the third case study, you can ask them right now. Other than that, this thing is on. This thing is getting recorded, right?
Yes, ma'am. Yes, ma'am.
So you can once again listen to the recording, and there, if you have any questions, you can post it in your group. Sweta ma'am or I or Ankita ma'am will try and give you the clarifications that you desire.
Yes, ma'am.
And you have three diet charts now, which you need to send to Sweta ma'am on the email. With this, we'll end today's session. Study whatever I've been explaining to you. Do your own study up. Ma'am, attendance kothay debo. Ankita ma'am will guide you about that.
I have already recorded the attendance, and you know the procedure after this video is posted in NutriSap. So the same goes for this.
Okay, then with this, we will be leaving, we will be stopping today's session. You can all leave the class. Thank you very much.